Okay, so first we're going to apply the curvilinear probe to find a suitable pocket. Generally, I like to do this both kind of a coordinated approach to landmark from a blind perspective, or anatomically, directly north or superior to the anterior superior iliac spine, and then basically vertically, horizontally cross from the umbilicus, and then apply the probe roughly in that position. This kind of keeps you lateral enough to avoid any inferior epigastrics. But we'll do both a low frequency and high frequency probe approach to make sure we minimize the risk of vessel laceration. So first we'll find a suitable pocket. This looks quite good. Looks very reasonable in terms of approach. Now, what I would do is I'd turn the probe 90 degrees to make sure we have an orthogonal plane where there's a suitable fluid pocket. That looks great. So we have a good distance here. In fact, if we place a caliper from the top to abdominal wall, we're about 3 centimeters. Then all the way to the bowel, or about 8 centimeters. That's a 5 centimeter difference. That is ample amount of space to make sure we don't actually penetrate to the point where we actually hit bowel. So that's great. Once we have this spot, okay, then we can take a blunt fill cannula needle and just place a small mark in the skin directly over the site. And then we'll change to a linear probe to make sure there's no vessels directly below that site. Okay, so we're next going to apply the linear probe and see. I'll just give you a hand here, change this. Okay, to, we'll go over this. That's right, okay. Okay, so we're going to look here to see. I can find just an abdominal wall. Right. Okay, and we'll apply some color Doppler to the area. Okay. I have turned down the Nyquist limit to increase our detection to see if there's any blood vessels at all in that area. Now, if this does not show anything, you can also put on color power Doppler as well, or CPD on this machine, okay, which helps us detect any vascular flow in the area. So if we're satisfied in this area, then you can go ahead and prep the patient and apply the drape. And generally during the procedure, I'd only advocate to put a sheath over the curvilinear probe, and that's more for a static ultrasound approach where we actually find the area, we mark it, we prep the skin, drape, and then use the curvilinear probe simply to make sure that we're, again, in the correct position. Okay, now we're going to prep the skin here. So we have some SoluPrep swabs, starting from the inside and just going to the outside. We'll do 3 swabs and we'll wait a couple minutes after to make sure that the antisepsis solution has had time to work. Looks great, a nice large area that's been prepared. Now we're going to set up the kit. And generally I encourage people to set up the kit so things are easily accessible and also laid out in the way that you'll do the procedure. So here we have our standard safety centesis tray, our centesis tray, okay, which is a catheter over needle approach. Okay, so now we're going to apply the standard sterile drape that comes in the kit. So we'll be cautious here not to contaminate yourself. Okay, nice. We've covered all the areas here. Just have the skin and an area surrounding. Okay, here we go. There's the curvilinear probe. Make sure that those elastic bands are nice and snug there around the tip so the plastic's well approximated. Okay, so come towards me. So here we'll make sure our tray is set up. We have all our catheters ready to go. Okay, we have some lidocaine in the tray. We have a local anesthetic needle, typically like a 25 gauge for the skin, maybe a 22 to get a bit deeper. Okay, we also have our Paracentesis needle. Okay, we have our drainage bag, or we have a standard vacuum container. Okay, so now that we're draped, let's examine the area again and make sure that we're satisfied with our mark and with our site to make sure we'll have a successful procedure. Oh. Okay, so we have a nice big pocket here. Okay, it's nice and clear, and we can see in orthogonal planes. And again, we've already examined the area with the linear probe to rule out any overlying major arteries or veins. Next, we're going to freeze the area with some local anesthetic. Okay, we've also made sure he has no allergies. We'll freeze the skin first, as we're doing here, and then we'll freeze deeper into the actual parietal peritoneum. Okay, now we're going to use a 22 gauge to get a bit deeper, as I mentioned. This can help us freeze a bit deeper into the tissue, but can also help us make sure that we establish a clear tract down to the peritoneum. That once we advance a bigger needle, that we are satisfied with the approach angle. Excellent. I see you're both aspirating and ejecting, making sure we get some good freezing. Also, we're not in a blood vessel. And we want to go to the point where we can aspirate some nice serous fluid if we expect typical serous ascites. There we go. There's some nice yellow fluid. We're satisfied with our angle here. Now we'll need to make a small nick in the skin prior to inserting the catheter over needle assembly. So a small nick in the skin. Next, if we hold up the Paracentesis needle in front of if you can just show me the different parts of the device there. So we can show the actual needle itself. The catheter on top, obviously, the white catheter in the blue hub. Okay, and then with the actual, there's the rigid stiffener on the inside / the needle. Okay, and so how this is going to work is, as you enter into the peritoneum, once you're able to aspirate peritoneal fluid, then the right hand will remain fixed. Okay, the right hand holds the syringe and the left hand will advance. Okay, that means that the catheter will advance over the needle. That way the catheter and needle don't advance together. Okay, so let's go ahead and do the procedure now. Excellent, so two-handed approach here. Again, following the same path we took with the local anesthetic needle. Okay, and aspirating, excellent. Here we go. Now your right hand remains fixed and left hand advances. Excellent. Okay, then the stiffener / needle is removed. Okay, at this point we have our catheter and stopcock assembly. We can take off some samples from here. So generally take enough samples off, that way we can do both anaerobic and aerobic cultures. Those are 10 mil injections into a vial times 2. And then usually 30 to 40 mils as well for more chemistry testing, like your typical culture and lights and the rest of the acidic chemistry. This can be connected to either a typical Foley drainage bag or it can be connected to a vacuum container. Here we have a vacuum container. Okay, so we're going to use this here. So this is already sealed, so I'm going to open it up and we're going to aspirate some ascites. Excellent. So that is largely the procedure. This device could be secured to the abdominal wall if you want a more long-term drainage, but typically we advocate for drainage with this catheter and then removal of the catheter, especially for this particular device. So again, you can use a Foley bag or you can use a vacuum container as we've shown here. Okay, the typical things that you can see with this procedure as troubleshooting is sometimes the catheter can get stuck on bowel. So what you can do is clamp off the vacuum on the container and just disconnect the drainage tube from the catheter assembly device and then just give it some air and then reconnect and go through the same process. But we did have a large pocket, so I do not expect that to be a major issue in this case. There are a variety of kits that can be used to drain off ascites. The Centesis kit we used here is available in various formats, whether it's called a safety Centesis catheter, or in some cases it may be called a Thor Centesis catheter, which can be a similar device by some manufacturers. Once we are done with our drainage, okay, the catheter and stopcock assembly will be removed. We'll place a 2x4 or 4x4 over the site, and then we'll ask the patient to roll decubitously onto the contralateral side. That just reduces the risk of ongoing acidic leak. Excellent, so that's the end of our procedure. We're going to keep draining here, but we want to thank you for listening.